Hello again. Welcome to the New York Medical College, Touro College and University System COVID-19 webinar. As always, I am your host. My name is Edward Halperin. I'm the Chancellor and CEO of New York Medical College and the Provost for Biomedical Affairs of the Touro College and University System. This is our 16th webinar. It has been 2 years this month since the first report of a new viral disease in Wuhan in China and the release of the genetic analysis of the virus. And this pandemic has had lots of ups and downs, but we're now 24 months into it, and this is our 16th webinar. So I suppose you could say that no matter what the ups and downs are, you can count on one thing, and that is about every 5 to 6 weeks, we'll be back to teach you what we need to know about the science and ethics and public policy and medical care related to the COVID-19 pandemic. I always spend a good deal of time worrying about the content of each of these webinars, and today's webinar is a trifle different than our other webinars because we've allocated varying amounts of time to our different speakers because of the amount of content we have to cover. We're going to first hear from the Dean of the School of Health Sciences and Practice at New York Medical College, Robert Amler, who's going to give us a 2-year overview of the pandemic, give us some advice about what we've learned about natural immunity, and then give us some advice for winter travel with the holiday season and New Year's upon us. Next, we've invited back someone who you met at our very first webinar 2 years ago, Professor Bakshi from the Division of Microbiology and Immunology of the Department of Pathology, Microbiology, and Immunology, because he's going to teach us all about viral mutations and variants, a very big topic right now. A fan favorite, Dr. Melissa Montecalvo, is back again, and she's going to talk with us about the evolving information about oral anti-COVID-19 agents. We've got someone new who you haven't met before, Professor Vaccarino from the Touro College of Business in Manhattan, because I thought it would be interesting to have a chat about when do you go back to work? When you're an employer, how do you get people to come back to work, physically come back to work when they've been working from home for close to 2 years? And what's the right thing to do for running a business and for the individual employee? And our last platform speaker will be Jennifer Ricker. Jennifer is the Vice President for Communications and Strategic Planning at New York Medical College. And she's going to teach us what she's learned through this pandemic about putting television cameras in the faces of MDs and PhDs and sticking microphones in their faces and saying, explain to the public what's going on, either on television or radio or in the print media. I think you'll find an interesting lineup of talks. And if you have questions for any of our panelists, go to the place on your screen where it says Q&A and type in your questions, and we will get to as many of them as we possibly can during the question and answer period, which will be moderated by Dr. Alan Kadish, the president of the Touro College and University System. You will hear from me during the panel presentations intermittently when I appear again to tell you all about how to get your continuing medical education credit and to try to persuade some of you to financially support these otherwise free webinars. Welcome, thanks for joining us, and we look forward to another interesting and engaging program.
I'm Dr. Robert Amler, and this is the pandemic at 2 years of age with more than 800,000 US dead. I have no conflicts to disclose. And here's a reminder that, again, this webinar is sponsored by Touro and New York Medical College's Center for Disaster Medicine. Here's our quick overview, dialing back to the dawn of the 20s. A modest-sized city in China, very large by our standards, began reporting really bad flu-like killer virus infections that then spread to the rest of China. Well, we all hoped and thought it might just blow by, but it did not. And by December, this very month, the virus has already destroyed millions of lives. It's trashed the economies of every nation on earth, and it's changed the fate of almost every family across the globe. And boy, we have learned, and we're still learning. And as we learn, we are filling in the pages of this manual of communicable disease control put out by the American Public Health Association. We've encountered the virus structure. We've looked at infectivity per case. Remember the R0 metric and how we learned that R0 was not the only factor determining spread of a virus. We looked at hand washing and actual studies showing what effective hand washing looked like. We looked at the sneeze from a different point of view than most of us had ever looked at before, realizing how expectorated droplets can travel large distances, and that was the birth of the 6-foot distance recommendation. We looked at masks. Remember N95s versus surgical masks versus cloth masks, and we learned the difference between those masks and the importance of wearing them, especially in group settings indoors. Well, here's the tally today. Right now, it's still awful. We have a total, since the pandemic began, of hundreds of millions of cases worldwide, more than 5 million deaths, more than 50 million cases in the United States, more than 800,000 deaths that I've mentioned, and in New York State, 2.8 million cases and more than 57,000 deaths. All of these numbers, certainly an undercount compared to what's really happened. Well, this strategy has worked. It has been robust. We've seen it work, not perfectly, but it does make an important difference. So let's run through these really quickly. Block exposure to prevent disease, treat disease to prevent complications, and vaccinate to protect. Well, the block was straightforward. We have our 4 W's and we still stick with them. Wear masks, wash hands, watch distances, and walk away from groups. Don't linger with lots of people with masks off. Not a good way to block the virus. We also know that this is easier said than done. We all know that because we've lived through it. Treating infection is another matter entirely. We've had great progress in development of antiviral drugs, and only this week, a new drug was announced by one of the major manufacturers. Immune-based therapy is used frequently, and anti-inflammatory drugs have a defined role in the treatment of more complicated cases. We know now that our vaccines are safe and effective, not perfectly so, but they do make a huge difference, and they've made all the difference since they have come into use around the country and around the world. If we look here in the United States, this is rate of hospitalizations in the over 65 group, going back to last January when the vaccines started to become widely available. The upper line is hospitalization rates in the unvaccinated seniors. The lower line in green, which you can hardly see from the baseline, is the rate of hospitalizations in vaccinated seniors. Say no more. From across the room, you can see that the vaccine has made a huge difference in hospital rates. But vaccine-induced immunity wanes over time. And over a few months, these boosters have now become what seems to be absolutely vital to keep up our guard in preventing infection. In the case of the 2-dose vaccines, they should be given at least 6 months after the second dose. In the case of the 1-dose Janssen J&J vaccine, they should be given at least 2 months or longer after the first dose. Now, part of the delay in ending the pandemic has come from the variants. We know that viruses commonly mutate. We know that most of those mutations are deadly to the virus, and they are essentially dead ends. But some of the mutations allow the virus to continue to propagate and infect people. And for each of those variants, we need to know the severity of the disease they cause, the efficacy of vaccines against them, how transmissible they are, how responsive they are to treatment, and how effectively we can test for them. According to those criteria, CDC and WHO have classified variants, and they've selected 2 variants that they consider variants of concern. They previously had some other variants of concern that were later washed away because they turned out not to be that significant. But Delta and now Omicron have turned out to be variants of concern because of their high transmissibility primarily. And in the case of Omicron, we are still studying how much of a consequence they amount to in terms of severity of disease and the ability to evade vaccine-induced immunity. In the meantime, so far, no variants of high consequence, which would be extremely alarming, have been identified or classified by CDC and WHO. But I have to warn you, by the time you're looking at this slide on Thursday afternoon, December 16th, there may be more information emerging on the Omicron strain, and you may have to stay in touch with the published media and the print and the electronic media to see what we are still learning about the Omicron variant. So with all of this, I'm asked by everybody, is it okay to travel again? Is it okay to travel? Well, look at these 2 widely disparate scenarios. First of all, how important is that trip to you? And how are you going to feel if you end up with the group on the left, or you can travel like the group on the right? Which is going to be better from the standpoint of virus protection? But you also need to think about the importance of your trip. So I cannot answer that question for you. Every traveler needs to decide. If you do decide to travel, think about how much you can tilt the odds in your favor to have a relatively uncrowded travel experience, where there are fewer crowds at the gate, fewer crowds on the plane, fewer crowds deplaning, fewer crowds at baggage claim. And the same basically applies to train and bus travel and any public conveyances that attract large numbers of people. You just need to think about how important that trip is and how careful you feel you can be to minimize your exposure. That, of course, begins by getting vaccinated and boosted as soon as you can. Because really, our long-term goal here is to achieve lasting protective herd immunity for everybody. That's going to come from 2 sources, from vaccinations and from natural infections that do confer immunity as well. We don't know how long lasting either form of immunity will be, and we don't know what percents we need to achieve in the population in order to have sufficient immunity that we can call it herd immunity and protect those who cannot be protected. So the answer is not only we don't know, but one thing we do know is that we're not there yet. We don't have that answer yet. So that leads to the final question, what's coming next? And to this, I refer to Peter Drucker's quote which Dr. Halpern used a couple of webinars ago. Drucker said, you cannot predict the future, but you can create it. Well, great. How do we do that for COVID? We can't create it perfectly, but there are three things we can do. We can vaccinate and boost, we can block exposure, and we can treat those infections as early as possible to contain the damage from a COVID infection. And that's the current status of what's coming next. Thank you.
Hello again. This is your host, Dr. Edward Halpern, to explain to you how to get continuing medical education credit for today's webinar. You have, as always, three choices. You can get out your cell phone and send a text message to 828-295-1144. And you should put in the message 75 COUP, 75 COUP. And if you do that, you'll get a text message back, which will walk you through the process to get your CME credit and fill out your satisfaction questionnaire with today's webinar. Another choice is you can go to our website, www.eeds.com, click the sign-in button and enter that same code, 75 and in all capital letters, COUP. And once again, it'll walk you through the process for the questionnaire and the CME credit, or you can take your cell phone if you have the app for QR code readings and hold it up to the QR code, and it will automatically take you to the website to walk you through doing your questionnaire and getting your CME credit. Please act promptly because the code's going to expire next Monday, December 20th at 12:30 p.m. Maybe you want to snap a screenshot of this or get your cell phone out and take a picture or write these numbers and codes down to be sure that you get your credit. We're going to continue with our webinar, and remember that if you have questions for any of our panelists, please type them into the Q&A box on the computer screen. And we're going to hear next from Professor Bakshi about mutations and variants of the virus. So let's return to our program.
Hi, good afternoon, everyone, and thanks for joining. My name is Chandrasekhar Bakshi, and I am an associate professor in the Department of Pathology, Microbiology, and Immunology. So today I'm going to give you a primer on COVID-19 viral mutations and their meaning. I have no conflict of interest to disclose. So let's start with the structure of the SARS-CoV-2, the causative agent of COVID-19. So this is a single-stranded RNA virus, and it has 5 major proteins. So of the 5 major proteins, the spike protein is very important because it is required by the virus for attachment and entry. As you can see here in this cartoon, that the spike protein binds to the ACE2 receptor on the cell for its entry. Spike protein is also a target for neutralizing antibodies, which are protective. And the spike protein is also a major target for vaccine development. And as I told you that SARS-CoV-2 is an RNA virus. So RNA viruses in general are very prone to mutations, especially when they are replicating at a very fast rate. And the mutations that are occurring in the spike protein of SARS-CoV-2 are of major significance. And let's see what are the consequences of mutations in the spike protein of SARS-CoV-2 that we have learned so far. So this is the map of the spike protein of SARS-CoV-2. It has 2 major subunits, S1 and S2 subunits, which are required for the attachment and entry of the virus. The S1 subunit has 2 domains, the RBD domain, which stands for the receptor binding domain, which has a receptor binding motif, which comes in contact with the ACE2 receptor. And then it also has an N-terminal domain. So the first variant of SARS-CoV-2 that was identified in September 2020 had 11 mutations in the spike protein. Beta variant had 10 mutations with 2 overlapping mutations with alpha variant. Gamma variant had 11 mutations and it had 3 overlapping mutations with beta variant and alpha variant. And the most dreaded Delta variant had 11 mutations and had only one overlapping mutation with the Alpha variant, whereas the newly identified Omicron variant has 37 mutations. So 25 of those are new mutations, which are all shown in the black letters. And the color letter shows that these are the overlapping mutations that are also observed in the other variants of SARS-CoV-2. So what we have learned from these mutations in the spike protein of these four major variants, that these mutations have increased the transmissibility, the ability to cause more severe disease or increased hospitalizations, and the reduced effectiveness and treatment, as well as vaccines and diagnostics against these variants. So based on these concerns, World Health Organization classified these variants as variants of concern. And now Omicron variant is also added to this growing list of variants of concern. So let's see what are the implications of mutations in the spike protein of Omicron variant on receptor binding and transmissibility. I've told you that this receptor binding domain contacts the ACE2 receptor. And this receptor binding domain of Omicron variant has accumulated 15 mutations. So there are very few studies, but this one particular study has shown that these mutations, especially which are shown in the red balls here, which are at the interface of the receptor binding domain and the ACE2 receptor, 6 of these 11 mutations increase the binding affinity of receptor binding domain to ACE2 receptor. Although 3 of these mutations have shown to reduce the binding efficacy, but overall it appears that these mutations are increasing the binding efficacy of the receptor binding domain of spike protein of Omicron to ACE2 receptor. So how about the transmissibility? So the data that are emerging from South Africa is showing that the Beta and Delta variants took about 100 days to achieve dominance. But Omicron has done so within 3 weeks. And a similar data is also emerging from England, especially in London, which is showing the rapid rate of transmission of Omicron variant. And also one of the studies conducted in Japan has shown that the Omicron variant is 4 times as transmissible as the Delta variant. So the next question is, do the mutations in spike protein of Omicron affect the vaccine efficacy? And as I said, there are very limited studies available. And this one particular study conducted in Germany, what they have done, they collected the serum from individuals that were immunized with different currently available SARS-CoV-2 vaccines. And then they determined the efficacy, the neutralization efficacy of the antibodies against Delta and Omicron variant. So what they report is that those who received 2-dose Pfizer vaccine, and this is 6 months after the vaccination, the efficacy against the neutralization efficacy against Omicron variant is reduced by 11.4-fold as compared to the Delta variant. Those who received a booster and 2 weeks after the booster, still there's a lower efficacy by 37-fold against the Omicron variant, and which drops further in those individuals after 3 months of receiving booster. Those who received the vaccine but got infected with COVID-19, again, their serum is showing reduced neutralization efficacy against the Omicron variant by 32-fold as compared to the Delta variant. And the similar results are also observed with other 2 vaccines, Moderna and AstraZeneca vaccine. There is one more study that also determined the efficacy of the convalescent sera against the variants of SARS-CoV-2. And as shown here, the efficacy of the convalescent sera is severely reduced against the Omicron variant. So the next question, the good thing about it is that the majority of the CD8 T cell epitopes in the spike protein, they remain unchanged. So this is the sequence of spike protein of Omicron, and these are all the mutations which are shown in light blue letters, and all those green boxes are the CD8 T cell epitopes. And as you can see that none of those are impacted by the mutations except the one which is shown in this red box. So The next question is, are the current therapeutics are effective against the Omicron variant? And these are the two studies that are available so far. And these show, one of these studies show that the monoclonal antibody cocktail have reduced capacity to bind Omicron variant. And this is against all the 4 emergency used authorized monoclonal antibody cocktails. So this indicates that the mutations in the spike protein are affecting the epitopes, and that thereby they are reducing the binding capacity of the monoclonal antibodies. And this study also shows that the Omicron variant is not neutralized by majority of the approved monoclonal antibodies. As you can see in the red and blue boxes, shows that the escape or the reduced efficacy of neutralization by these monoclonal antibodies. However, the good news is that except for bamlanivimab, all other monoclonal antibodies remain effective against the Delta variant. So to summarize what I have told you today, that the mutations of the spike protein of SARS-CoV-2 are of immense significance because they have shown to enhance the transmissibility and the immune evasion capabilities of the SARS-CoV-2 variants. And whatever the initial preliminary studies and the predictions indicate a higher transmissibility and immune evasion capabilities of the Omicron variant as compared to the other known variants of SARS-CoV-2. And with that, I will stop here, and thank you so much for your attention.
Hello again, this is your host, Dr. Edward Halperin, to remind you to consider giving back to New York Medical College to support these webinars. These webinars are provided at no charge to you. Indeed, for those of you getting CME credit, there is no charge for the CME credit. But free webinars and free CME credit are, of course, not free. The college has considerable expenses putting on these webinars and generating the CME credit. We hope that some of you will choose to financially support these webinars and our research on COVID-19 at New York Medical College. Our programs require time, effort, and funds, and by making a tax-deductible gift, your donation will help offset our costs. Great things are happening at New York Medical College. We hope you'll all choose to be a part of it, to make a gift back to the college to support this webinar. You can phone 914-594-2720. And one of our development officers will be happy to take your credit card information over the phone. Or you can go online, www.nymc.edu/give, and make your donation online. And if you like to use the high technology of a pen and a checkbook, that works for us too. Checks may be made out to New York Medical College. Please write in the memo line of your check supporting COVID-19 webinar or supporting COVID-19 research. Put it in an envelope with a stamp and send it to New York Medical College, Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, 10595. And we thank you for thinking of us during these challenging times. We hope everyone's staying safe and healthy. Remember, if you have a question for any of our panelists, go to the Q&A function on your computer screen and type it in there, and we'll monitor them and get to as many of them as we possibly can during the Q&A session of today's program. And let's get back to the presentations by our panelists.
Good afternoon. I'm Marissa Montecalvo, and I'm speaking to you about the oral potential treatments for COVID-19. I have no conflicts of interest to disclose. So these are the current outpatient treatments that we have, and they are the monoclonal antibodies, of which we now have 3 choices. They must be administered intravenously or subcutaneously, and they are for persons with mild to moderate disease at high risk of disease progression. Just recently, the emergency use authorization for monoclonal antibodies was expanded to include treatment as post-exposure prophylaxis. So not just treatment for symptomatic individuals, but if you were exposed, and at high risk for disease progression, and someone who is thought to not mount an adequate immune response, these monoclonal antibodies are now available. So I mention this because treatment and post-exposure prophylaxis is often a route that medications go. What about oral treatments? So in last week's Science Times, you may have had the opportunity to read about the Merck and Pfizer drugs that are forthcoming. As we get to those, I thought it would be useful to review the stages of viral replication, at least the beginning, because that gives you an idea where drugs can act. So in the first photo, you've seen this many times before. This is SARS-CoV-2 approaching the ACE receptor of the lung, and this is where monoclonal antibodies interfere with that binding. But once the virus has attached to the ACE receptor, you now have intracellular virus that releases its RNA. And in photo 4, you see the complicated structure where the RNA is within our ribosomes and is producing polypeptides, which are proteins that will be essential for replication. These polypeptides have to be broken apart at specific places, and it is proteases that break them apart. And the Pfizer drug, Paxlovid, is a protease inhibitor interfering with those cleavages. After the polypeptides have been broken apart, they come together and surrounding the RNA. This is where new RNA of SARS-CoV-2 is formed. And it is in this transcription stage that the Merck drug, Malnupiravir, interferes with replication. So Malnupiravir is a drug that looks like the nucleoside cytosine. It's a prodrug, and once in plasma, it takes on 2 forms. And here's what happens. It gets into RNA and mimics cytosine. And so when SARS-CoV-2 goes to replicate and RNA polymerase comes in, it gets all confused, putting in other nucleosides. And so you end up with many errors, which results in what's called a viral catastrophe. It cannot replicate successfully. At the bottom, you see the actual inhibition of antiviral activity, both against the original Wuhan strain and variants of concern. What about clinically? So the outpatient trial first had an interim analysis and then the final analysis. So this trial was conducted in unvaccinated persons that you had to be at risk for disease progression. And it was a placebo-controlled trial for persons with laboratory confirmed SARS-CoV-2 within 5 days of symptom onset. They had to receive either Malnupiravir or placebo, with the endpoint being hospitalization or death within 29 days. And here are the data. So the interim analysis is here, and there was approximately a 50% reduction in hospitalization and death, highly statistically significant. But when the full population was evaluated, this difference closed in a little. However, still statistically significant, with 6.8% of Malnupiravir treated patients having hospitalization or death versus 9.7% of placebo-treated patients. Another way to look at this is that to prevent one hospitalization or death, one would need to treat approximately 34 patients. There are some safety concerns with this drug. Although there were no safety concerns in the trial that were evident, in theory, there are concerns. So in animal models, there are issues with abnormal growth plate. And so a pediatric trial has been delayed at this point. There is known bone marrow toxicity in animal models that was looked for carefully in the clinical study and not seen. There is fetal developmental toxicity in animal studies. The trial excluded pregnancy, and currently the drug would not be authorized for any use in pregnancy. there is the potential for mutagenicity. It's creating mutations. What if these got into our DNA? But the animal studies thus far do not support that. And lastly, as Malnupiravir is tricking the RNA polymerase, it is producing some variants in spike protein that aren't viable and were not found to be clinically significant, but there is this process going on during the period of replication. So at the FDA hearing, this was looked at very carefully, and in the end, they voted to move the drug toward EUA. The 13 who voted for that did it predominantly because it's meeting an unmet need. However, it cannot be used in pregnancy given the current data, and there are still safety concerns. And they did say that if another drug with fewer safety concerns becomes available, this EUA should be reevaluated. 10 voted against, feeling that the safety concerns and the potential production of variants outweighed the benefit of treatment. And so it is decided to move it toward EUA with the indication being treatment within 5 days of symptom onset for persons with mild to moderate COVID-19 at high risk of disease progression. The other drug is the Pfizer drug, which is the protease inhibitor, and there is less information available about this right now. The drug is named Paxlovid, and it is this drug in combination with ritonavir, which increases the levels of the protease inhibitor. You're probably familiar with protease inhibitors. They are this mechanism of action are drugs that revolutionize the treatment of HIV infection. So again, it is inhibiting this cleavage. The trial for Paxlovid was performed in unvaccinated adults, again at high risk of progression, treated within 3 days of symptom onset, same endpoint. And in the interim analysis, the trial was stopped because of a highly statistically significant benefit for the Paxlovid treated patients. So where are we? Well, Malnupiravir and Paxlovid are both being looked at for use in patients at high risk of disease progression to severe disease within 3 to 5 days of symptom onset, and they both have demonstrated statistically significant reductions in hospitalization and death. The FDA has voted favorably to move Malnupiravir toward emergency use authorization, but this would be as it was done in the trial for unvaccinated persons at risk of progression to severe disease. The EUA has not yet been issued. There are concerns about how the use of this drug would be restricted. It would be hard to do that. What happens when a vaccinated person is symptomatic? And so that is all still being worked out, and there may be a need for some monitoring for safety concerns. Paxlovid in combination with ritonavir has promising data. And the role of these drugs for treatment and how they stand up next to monoclonal antibodies is of course yet to be defined. If they become available for treatment, they will also be looked at as options for post-exposure prophylaxis. Where we stand right now, I think I just want to close by saying that vaccination remains the best prophylaxis. These are my references, and I look forward to your questions. Thank you very much.
Good afternoon. My name is James Skip Vaccarino. I'm an adjunct professor at the Touro College Graduate School of Business and the Director of Career Resource Services. I have no conflict of interest with the topic that I'm about to present. How companies are managing and should be managing the post-pandemic workplace. Returning to the office. We should definitely keep in mind and that we need to be transparent and that measures are taken for the safety of our employees. It's not going to be easy, and open communication makes employees' safety a priority. Give them the needed time to adjust. Remind them that The transition to online was very quick. The transition to the office is going to take a major adjustment. There are so many things that have changed coming back. Commuting to the office might have changed. The availability of commuting and how we commute has changed. We must definitely make sure that we're aware of childcare needs for those employees that's necessary. Give them a say in what works best. Employees take a big role in focus groups, and give them the power to decide what's best for them and for the company. Share hard data with them as backup. What things are happening in the workplace. It's known that with this transition to remote work, that productivity maintains a certain great level. However, we do know that productivity and creativity and idea generation sometimes has a better influence with large groups. So companies have transitioned to what's called hoteling, where the employees can go and reserve an office, reserve a conference room, so that they can meet together in groups to make sure that productivity does stay high. Find more ways to listen to their employees, opportunities to listen, how our changes reflect their expressed needs and wants, that we make sure we tell our employees that we hear you. Work to get an alignment from across the company. Stay flexible and meet constant changes. At times of crisis, the way we treat our employees matters. Have a very flexible transition plan. Flexible, constant changes are coming. No one size fits all. Expect the changes, anticipate the changes. Balance the needs of the employees with the needs of the company. The pandemic changed the way we view work-life balance. Companies need to balance what's best for the organization and what's best for the employee. Consider a hybrid model. Hybrid's becoming a permanent part of the office landscape. People will be working from home indefinitely. In fact, I'm told that new hires negotiate the time that they'll be working from home versus the negotiation for compensation. Have a clear and accessible safety protocol. Remain in the workplace to encourage social distancing and make visible cleaning protocols. Make returning to the office optional. In best case, make it optional for a very long period of time. Flexible policy creates trust. And as I said, the top negotiation method is negotiating your time working from home versus compensation. Thank you for listening.
Hello again, this is your host, Dr. Edward Halperin, to remind you to consider giving back to New York Medical College to support these webinars. These webinars are provided at no charge to you. Indeed, for those of you getting CME credit, there is no charge for the CME credit. But free webinars and free CME credit are, of course, not free. The college has considerable expenses putting on these webinars and generating the CME credit. We hope that some of you will choose to financially support these webinars and our research on COVID-19 at New York Medical College. Our programs require time, effort, and funds, and by making a tax-deductible gift, your donation will help offset our costs. Great things are happening at New York Medical College. We hope you'll all choose to be a part of it, to make a gift back to the college to support this webinar. You can phone 594-2720. And one of our development officers will be happy to take your credit card information over the phone. Or you can go online, www.nymc.edu/give, and make your donation online. And if you like to use the high technology of a pen and a checkbook, that works for us too. Checks may be made out to New York Medical College. Please write in the memo line of your check supporting COVID-19 webinar or supporting COVID-19 research. Put it in an envelope with a stamp and send it to New York Medical College, Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, 10595. And we thank you for thinking of us during these challenging times. We hope everyone's staying safe and healthy. Remember, if you have a question for any of our panelists, go to the Q&A function on your computer screen and type it in there, and we'll monitor them and get to as many of them as we possibly can during the Q&A session of today's program. And let's get back to the presentations by our panelists.
Hello, I'm Jennifer Rickert, Vice President of Communications and Strategic Initiatives at New York Medical College. And today I'm going to be discussing healthcare providers speaking in the media during the pandemic. I have no conflicts to disclose. It's been almost 2 years since our first COVID symposium, and over the past 2 years, our healthcare providers have worked hard to deliver up-to-date information on the virus to the public. And one of the main ways we've been able to do that is having them speak in the media on various different topics. And something we learned right out of the gates is that it's very important for the healthcare providers to be at the forefront of getting this message across. And rather than being reactive and waiting for journalists to contact us to do interviews on certain topics, it's important for us to know the important topics that the public need to learn about and approach journalists about that. This all started back in about January 2020. I actually had one of our infectious disease experts in my office, and she said to me, "There's this virus in China. Have you heard about it?" And I said, "I'd heard a little, but it wasn't really being covered in the news that much." So I said, "Well, what are you hearing about it?" And she said, "I've been tracking it, and I believe it's going to spread to the United States, and I think it has pandemic potential." And I said, "Well, if that's the case, it's definitely a public health concern, and we should be speaking in the media about it." So I contacted Dr. Antler, who is the Dean of our School of Health Sciences and Practice, but he's also been a speaker at almost every single one of these COVID symposiums. And he's a former employee with the CDC. And I asked him if he had heard about the virus, and he said, in fact, he had. And I said, "Do you think this is something that the public should be aware of? Are you willing to speak in the media about it?" And he said, "Absolutely." So we started pitching him out, and he appeared in every single top tier media outlet speaking about COVID. And he has continued to do that over the past 2 years. And another thing we learned right away is that the journalists needed to be educated on the different research and developments and aspects of the pandemic. So before the cameras even rolled, before interviews even went live, we were sitting with reporters and talking to them and having the healthcare provider explain the latest topics with them for over an hour. So it was really a different way that we had to approach journalists, making sure that we were educating them before the cameras even rolled. We were also making sure to clear up any misinformation that was out in the media and making sure our healthcare providers were presenting facts to the public. We also had to make sure the healthcare providers were kept up to date on the latest developments, because this pandemic has evolved so rapidly that it's been important for our healthcare providers to keep up on research so that when they are delivering information, they make sure that it is as current as possible. And finally, there's been so many developments with the pandemic over the past 2 years that we've had to work with various different healthcare experts to speak on different topics. For example, in the beginning, it was really, what is this virus? How do we stay safe? We were talking a lot about hand washing in the beginning. And then we started talking about mask mandates. And then it was the different variants and vaccines. And now we're talking about things like long COVID. So when you see a healthcare provider speaking in the media, how does that take place? How do they become an expert that the media want to speak with? Well, that's done in 3 main ways, which I'm going to go over today. One of them is what we just talked about, which is when you see a topic in the media and either you're an expert in that area or you have an expert, if you're a PR person on your faculty in that area, and you pitch to the journalist and say this person is available to talk. Another is an inbound media inquiry, and that's when a journalist reaches out to a healthcare provider and says, can I do an interview with you on a certain topic? And the final way is via an editorial, and that's an opinion piece that a healthcare provider will write on a topic and then have it published in the media. So with pitching to the media, what you want to do is track the news. You're going to want to actually watch the news, read the news, see what topics are being covered. And if you see there's a topic that you're an expert on, if you feel like you can add to that conversation and inform the public in a new way on that topic, or if like us, you see there's a topic being discussed in the media that maybe needs more coverage or in a different direction, you can pitch out yourself as an expert and say, I am an expert in a certain area. Typically what you would do is send an email to a journalist. You would find a reputable outlet that you would want to work with, and you email them and say who you are. So what is your title, your background, what makes you an expert in that area? What topic would you like to discuss, and possibly put together a quote of what you would say so the journalist has a really good idea of the topics you would cover. And if you've spoken in the media previously, you'll want to also send a link to your prior coverage. So this way journalists will know if it's on camera, how you speak in the media, or if it's in print, how your quotes come out. And then you'll also want to provide your contact information. So the more an individual is in the media, or even if they publish a report or a research or something, journalists are going to see that. And when they see that, they're going to say, well, this is someone that is very knowledgeable in this area, and I would be interested in working with them. So then they would reach out to that individual. So that's called an inbound media inquiry. So that's when typically you get a phone call or an email from a journalist saying, I'd like to speak with you on a certain topic. So there's some very important things you want to do when you get that inbound media inquiry. The first one is you want to vet that request. And by that, I mean, you want to make sure that the person contacting you is who they say they are. So you want to do a little homework here. You want to make sure, is this individual actually a reputable journalist with an outlet that I would want to work with and do an interview with? Then you also want to look at some of their prior media coverage. Are they presenting stories in a way that you find factual? And is this an outlet that you would want to be associated with? So if all of that checks out, then you're going to want to find out, well, what's the deadline? Journalists may be working on a piece that needs to air that evening, so they may only have 2 hours to put together their story and write an interview. So if you're a physician and you're seeing patients, that may not work for you. So it's very important to just right out of the gate say to the journalist what your availability is. And you may say, you know, I'm seeing patients until about 5 o'clock, or maybe I could do it tomorrow morning. And if that's going to work out, they may be flexible with you. Other than that, they're going to have to move on to another expert to do the interview with. Next, you're going to want to ask for sample questions. It's perfectly reasonable to ask a journalist to send you sample questions prior to the interview. So this way, you know the exact direction the interview is going to go in, but also then you're able to prepare for the interview. Make sure you know exactly what topics are going to be covered. And finally, you're going to want to know, what type of interview is this? Is it going to be in print? If so, then you can typically just write out your responses and email them back to the journalist. Or is it on camera? Maybe it's a radio interview or even a podcast. Now, some other things that have changed over the course of the pandemic is, prior to the pandemic, we were typically having our healthcare providers go into a studio to do an interview. And then you have a producer that's controlling the environment for lighting, sound, background. But now a lot of these interviews are taking place via Zoom, or the journalist is actually coming to the healthcare provider's office to do an interview. So now you are going to be responsible for controlling that environment. And there's some important things that you want to think about. One is, are you doing the interview in an area that is quiet? I think we've all seen those interviews. It's very amusing when someone's doing an interview and someone comes into the room, maybe a child, but it does distract from what the expert's trying to say. And the coverage then becomes about this cute moment with the expert being caught off guard by their child. So if you're doing an interview at home or in your office and there's people around, you want to make sure you tell them that you're going to be doing an interview and try to keep the noise level down, give you privacy during that time. You also want to think about your background. If you're doing a Zoom interview, you could always do a Zoom background, or just make sure when you're doing an interview, there's nothing distracting in the background. You want people focusing on what you're saying and not looking at what's in the background. And you also want to make sure there's nothing too personal in the background, like maybe a family photo that you don't want out in the media. Next, when you're doing the interview itself, there's some do's and don'ts you want to focus on. One is, if you're talking about COVID, just remember that the audience, a lot of people are very nervous about this. They could be on edge. And as a healthcare provider, it's very important for you to think about your delivery. Make sure that you're speaking in a calm and reassuring manner. Also, you want to think about how you're dressed, just like your background. You don't want to wear anything that's too distracting. You want people focusing on what you're saying and not be distracted by what you're wearing. So it's appropriate to wear something that you would wear if you were seeing patients or if you're going into an important meeting. Next, keep your responses concise. If you're asked a question, answer that question, then stop talking. You don't want to go on and on or talk about other topics outside of what you're being interviewed about. Just remember that if you're doing an interview and it goes on for an hour and a half, the final piece is going to boil down to, if it's on camera, about a minute. And if it's a print publication, it's going to be about a sentence or two. So if you're talking on various different topics, you don't know what final piece the reporter is going to run. But if you're staying on topic and keeping your responses concise, then you'll make sure they don't run anything that you wouldn't be comfortable with. Finally, the last question a typical reporter will ask you is there anything we haven't covered today or any topics that you want to discuss? Now, this is a perfect opportunity for you to think about before the interview. What topics do you want to cover? What are the really important key messages you want the audience to know? And then this is your opportunity in a very clear, very concise way to get that message across. And what we have found is typically during these interviews, it's that last segment that they're going to use and run. Things to avoid. You are there to speak as an expert on a specific topic. So if you're there talking about COVID and the reporter starts asking you questions about politics, you should feel very comfortable saying to them, that is outside of my area of expertise. You may want to ask that question to someone else, and then they'll just move on to the next question. Next, you want to make sure that when you're speaking, you're not using any technical terms or medical jargon that wouldn't be understood by the general public. And finally, don't be tempted to say anything off the record. Maybe you're doing an interview with a journalist and you feel like you have a great rapport and you say to them, you know, between you and I, off the record, I don't agree with the governor's latest mandate. Just know that they can air that. So when you're doing an interview, only say things that you would be perfectly comfortable with it running in the media. And finally, don't give opinions. You are there to speak as an expert and present the facts on something. So if they say, you know, in your opinion, when do you think the pandemic's going to end? You want to avoid questions like that. So the only time that there's an exception to giving your opinion is if you work on an editorial. Now, this is an opinion piece written by an individual on a particular topic. So if you're watching the news and you think there's a topic that you feel very passionate about, you have a strong thought about that, this is a way for you to get your complete thought out on a topic. These pieces are typically about 500 to 750 words. There's plenty of resources available on how to write a strong editorials, and here's some tips. We won't go through all of that, but just know that this is where you can put in your personal experiences, anecdotes, what you're noticing. If you think there's trends in a certain area, if you have recommendations, you think if we're going to move the needle on this, I really think we need to do X, Y, and Z. This is a good forum to do that. And as I said earlier, when our experts were doing interviews, sometimes an hour-long interview is only boiling down to a quote or two. And this is an opportunity for an individual to write a piece that gets their entire thought out, a full thought on something without being told through the lens of a journalist. So it can be a very effective way of communicating with the public. And over the course of the pandemic, we have worked with our faculty members, and we've been able to place over 200 editorials on a variety of topics. So it has been extremely effective. And as the pandemic continues and there are more topics that come up, our healthcare providers will continue to speak as experts, and I hope this has been helpful. Thank you very much.
Hello again, this is your host, Dr. Edward Halprin, to remind you about getting your continuing medical education credit for those of you who are seeking credit. 3 ways to do it. Send a text message to 828-295-1144. Type in the message the activity code 75COUP, and you'll get a response back walking you through the process for filling out your satisfaction questionnaire and getting your credit. Or you can go to www.eeds.com, click on the sign-in button, enter that same code 75COUP, and do the questionnaire and get your credit. Or get your electronic device, scan the QR code, it'll take you to the website for the same process. Be sure to go about your business promptly about getting your CME credit, because these codes are going to expire on Monday, December 20th at 12:30. If you have a question for any of our panelists, please be sure to type it in on the Q&A box on your computer screen. And we're now going to turn our attention to the question and answer portion of our program, where your questions will be posed to our panelists by our question and answer moderator, Dr. Alan Kadish, the president of the Touro College and University System. So Dr. Kadish, the podium virtually is yours.
Thank you very much. Let's start with a question for Dr. Bakshi. Do you think the virus was released from a laboratory or developed naturally?
That's a good question, but so far, actually, there's no scientific evidence to prove that this virus was engineered in the laboratory and was released intentionally. So as far as the scientific proofs are concerned, this is not a possibility.
Are you convinced then that it occurred naturally?
The possibility is it occurred naturally because, again, the epicenter of the spread of this virus was a wet market, the animal market in Wuhan. But again, because the evidence could not be collected from that market because it was sanitized, the very next day, the first case was reported from China. So, and based on the scientific evidences, like the sequence homology, it appears that it originated from bats. But again, we do not have any clear-cut indication of what is the transmission host, or whether it jumped directly from bats to humans. From all other scientific evidences, it appears that this virus originated as naturally rather than as an intentional release. And that was an excellent question.
Thank you. Is it possible that the Omicron variant will spin off additional mutations more rapidly than previous mutations because it's already so mutated?
Yeah, so that's again a very good question, because so this Omicron variant is just identified 3 or 4 weeks back. And what the sequencing results are showing that there are 300 different variations of Omicron itself. So I told you in one of my slides that it has 37 mutations in the spike protein, and there are 300 different variations of those mutations. So there are 300 different strains of Omicron itself which are circulating right now, and they are like divided in 60 groups. But as of now, what we have seen from the epidemiology or the phylogeny of all the variants, it appears that they are not originating as a result of replication of one. Like, for example, Omicron did not originate from Delta variant. It has a separate lineage, and it has originated independently of the other existing variant. But again, you can never leave to the possibility that, like, if the virus replicates, and because these are RNA viruses, they are more prone to mutations, there might be some spin-off from an Omicron variant. Thank you so much for your question. Yeah.
Sure. Next question. And these questions are from the audience, not from me.
Oh, okay.
I'm confused. If the efficacy of the virus wanes over time, why bother with boosters? Won't they just wane too?
Very good question. So basically right now, the efficacy of the vaccine is tested based on one parameter. That is the level of antibodies. And the level of antibodies, as the level of antibodies are waning or going down, it is assumed that the efficacy of the vaccine goes down. And that's why the boosters were recommended based on what was going on 3 months back, because the levels of antibodies going down. And as soon as the booster dose was initiated, the levels of antibodies rose. So if I give you an example of Delta variant, for example, so after 6 months of vaccination, the efficacy against Delta variant neutralization efficacy was 47%. But after booster, it went to 100%. So what I have shown in my slide is the comparison of Omicron with the Delta variant. So right now, the efficacy of the currently available vaccine, or the currently available regimen of the vaccine, has 30 to 40-fold less neutralization efficacy as compared to the Delta, because like Delta variant is now taken as a standard.
Sure.
So even though the efficacy is going down, that doesn't mean it has gone to zero. And I have also shown that the T cell epitopes, which is also an important arm of immune response, those are not changed as a result of mutations. So the net outcome of a vaccine is the combination of antibody and cell-mediated immune response. So yeah, so we cannot say that the boosters are not going to be effective.
Thank you. So we'll let you rest here for a moment and bring on Dr. Montecalvo.
Thank you.
So a follow-up question, Marissa, about vaccine boosters. Is it true that the Moderna vaccine as well as the Pfizer vaccine have lost 50% of their efficacy by 6 to 8 months? And if so, how can we rely on boosters?
That's an excellent question. So I don't think it's fully true. And I think that Dr. Boschke addressed this in part. So we have to always remember that there are two arms to the immune system, right? There's the humoral arm, the B cells, and the cell-mediated immunity. And it's much more complicated than that. But from an ID perspective, I'll just keep it at that. So your memory cells are extremely important. And when these boosters were reviewed by the American College of Immunization Practices, they were reviewing the antibody response, as Dr. Boschke was just saying, and but there is also the memory response, which is quite good, and so it's not as bad as that sounds. It really isn't. But I think, because we don't know that much, we're just at a year from the first approval, right, of the vaccines. So you want to keep those antibodies as high as possible, particularly since we all know there's breakthrough infection.
Would you recommend that young people get boosters too?
Yes, at the appropriate time, 6 months after a messenger RNA and 2 months after a vector vaccine. Yes, because although they're young and although they may not be at risk for severe disease as a much older person might be, they're also more likely to be exposed. I mean, they have a different life than an older person.
So what's young these days? How young?
It's younger than me.
At what age has the vaccine been approved, and at what age do you think boosters should be administered?
Yeah, thank you. So, the vaccines are all getting approved in pieces. Okay, so 5 and up for Pfizer. Okay, let's talk about primary immunization. For the Pfizer vaccine, it's age 5 and older is approved, is authorized. Okay. For the Moderna vaccine, it's age 18 and over is authorized, and the same for the Janssen vector vaccine. When you get to boosters, the boosters were initially authorized for age 18 and over. The Pfizer just last week got authorization to start at age 16 to boost. There's one other situation I want to address, which is if you are severely immunosuppressed, that is getting cancer chemotherapy or a biologic resulting in immune suppression or a transplant recipient. In those cases, you're eligible for a 3rd dose of vaccine, which is 28 days after dose 2. And that is from age 12 and up for Pfizer and 18 and up for Moderna and Janssen. And that's different from boosting. Those people actually get 3 doses in their primary series and are then eligible for a boost.
So since you just mentioned the different vaccines that are available, let me just ask you a question that's been asked several times, but is still very timely. What about mixing and matching vaccines? So would you?
Yeah, this comes up all the time. The primary recommendation was to stick with what you had. In terms of the messenger RNA. And I still advise that. And the reason for that is that remember that there are tens of thousands of people under clinical study from the original trials that are receiving boosters with their primary vaccine, whereas the crossover study is quite limited. I mean, that's an NIH-funded study, and there are the groups. When I looked at it last, there were 50 in each arm for crossover. So I think there's more going on now, but still, that is the recommendation. When it comes to the Janssen vaccine, there are many people, choose to switch over to a messenger RNA, and I think that's appropriate.
Someone mentioned that there's some reports of autoimmune diseases occurring with some of these vaccines. And as we give additional shots, do you think the risk of autoimmune disease is real? And will the risk increase as we give additional shots?
Way to know. I think that there are some situations of some manifestations that are temporally associated with vaccination, and it's, in some of those cases, it's very unclear what's going on, and I think that's why it's very important that these things be reported to CDC, to the company, and also, that to work very closely with an infectious diseases or an allergy immunology physician on these things. This is a work in progress, and I don't think we know the answer to that, but I do think the numbers are low.
So last question for you, and then we'll let you take a break. You talked a little bit about side effects in pregnant women and children. What drugs can be used to treat COVID infection in pregnant women and young children? Are there any safe drugs? What would you do?
Yeah, so the oral drugs that I spoke on are not going to be available for pregnant women or for, Malnupiravir. They were not in the trial or for young children. Those studies would still have to be done. So those those will not be available at this time.
And how about monoclonal antibodies?
Yeah, I think they are. I mean, in general, if you were immune suppressed, so the monoclonal antibodies are available, for anyone at high risk of disease suppression. So often that's at high risk of disease progression. Often that's older folks and people with underlying illnesses. So if there were a situation like that in a young child, it is available, and whether a pregnant woman in general with COVID-19 is eligible for monoclonal antibodies, I think so, but I actually would have to check that. I'm not 100% sure, because they are obviously at high risk of progression.
Can we have Dr. Amler join us for a moment? And I want to ask both of you a question. Rob, you want to come on?
Yes.
Great. So how would you compare the immunity that is achieved by having had COVID-19 to the immunity from the vaccines? So we'll let Rob start, and then Marissa, you can add.
Yeah, we'll jump in. The so-called natural immunity, or immunity you get from getting the wild virus, first of all, presumes that you didn't die and you're still alive. Okay, that already takes out 800,000 Americans from that comparison, compared to a very, 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 very smaller number on the vaccine side. So given that you did not die from the infection, what are your chances that now you have more immunity than you did from the vaccine? Well, we do know there are breakthrough infections in people who've been vaccinated. And yet empirically, we have all seen friend after friend after friend who has had documented COVID infection unvaccinated several times over. So it's clear that natural immunity is not fantastic. Give an example from some 40 years ago when the CDC recognized, where it came to measles immunity, that a documentation of measles infection, a diagnosis made by a physician was and still is considered acceptable evidence of immunity to measles. When you get measles, you're immune to measles for the rest of your life. That is obviously not always true for COVID. And I'll pass the ball to Dr. Montecalvo.
Yeah, so as Dr. Amler just said, this is the disease where natural immunity is not as good as one would normally have from natural immunity. A couple of months after infection, people seem to have some protection, and then it wanes. So I think, at this point, with all the variants and everything that's been going on, I think you just continue to get vaccinated irrespective of whether or not you've had COVID before. I think that's the bottom line. And you stay on the same vaccination schedule, and maybe you'll be a little bit better off than the person who never had it. Maybe.
I would finally say there are studies right now from different parts of the world that compare experiences in groups of people who were vaccinated versus groups who were not. These have to be matched type study designs, because if they're not matched, there could be so many differences in ages and backgrounds and other background medical information between the groups that it'd be very hard to tell if you're really comparing what you think you're comparing. Remember too, that even with careful statistical matching, you simply cannot match by behavior of the individuals. People who are fully vaccinated may well be more encouraged to go around and risk exposure more than those that have not been vaccinated. And that also, just this disparate effect of personal behaviors can also skew results. We will eventually get an answer to that question, but I think that answer will be coming fairly late. And thanks for a great question.
Sure. The bottom line is we're not sure about how good natural immunity is over time, and the recommendation is still to get vaccinated regardless of whether you've had COVID or not.
Correct.
So Dr. Amler, I've got a couple additional questions for you. Thank you so much, Dr. Montecalvo. Is it true that Omicron is more contagious but less lethal?
Well, I'll tackle it first. Thanks for the question. It's obviously more contagious because it's crowding out Delta in many parts of the world based on what we've read. I read just this morning that in the US, the CDC is saying the percent of cases out there that are Omicron have roughly doubled about every week. And so this clearly is crowding out Delta, which means it's more effective as a predator at getting out there. So yes, it is much more contagious. The question is it less lethal? Is it more lethal? Is it more severe? Is it less severe? We've seen some unpeer-reviewed studies that have come out of places like South Africa, some other parts of the world, I think Belgium, if my memory serves. But as our Chancellor, Dr. Halperin, often says, the plural of anecdote is not study, and the plural of study is not peer-reviewed study. So I think we still need to look at those data. It's encouraging that so far, at least I have not seen evidence that Omicron is more lethal, but I would say we need to wait and to get more definitive information from all of these observers around the world. Thanks for the question.
Sure. Would you recommend at this point a ban on group gatherings for people who are not vaccinated?
Well, as a physician epidemiologist, I don't ban things. That's a decision that's made by our elected leaders, and hopefully they get the benefit of the best advice around the country before making some very tough decisions about freedom of movement and personal freedom and so forth. I am recommending to organizations in our area that they look at the importance of a meeting very carefully to see if it really needs to be in person right now, or if the same objectives can almost always be accomplished by a virtual gathering. Skip spoke earlier about the process in business now of hoteling, which makes a lot of sense, not requiring people to come back into an office, but at least allowing them to reserve a conference room for a particular purpose, for a particular period of time, under more controlled conditions. Since at the moment, we seem to be going into a new surge, certainly in the New York area, as well as around the country, I think that decisions for groups to get back together should be taken carefully. Thanks for the question.
So how concerned are you about this new surge?
Well, I was less concerned a month ago when there was a hint of it. I'm much more concerned today when we look at the actual numbers. I can tell you that in Westchester County, where my office is located, we were seeing very, very small numbers of new cases on a daily basis. And now in the last several days, each day, according to the state data, we are seeing hundreds of cases, and not just 101 or 102, but 400, 500, 600 cases in a single day. Since the reporting mechanism has not changed radically during this time frame, I conclude that there is a surge and that it's real. Thanks for the question.
Sure. Last question for you, Dr. Amler. We've talked a lot about herd immunity. There was some talk about it today, and we've talked about it in the past. We've got a lot of people vaccinated. When will we actually get to herd immunity?
Thanks again for the question, and I feel the frustration of the questioner. The whole point is we have been, as again, Dr. Halpern said at the very beginning, we have been working on this 24/7 for a full 2 years. And everybody occasionally picks up their head and said, when is this going to go away? When is this going to end? I want to see this in the rear view mirror for a change, instead of worrying about what's up ahead on the road to come. Unfortunately, we are not there yet. Herd immunity for any given disease in any given population with certain behavioral factors that cause people to interact more or interact less. That kind of immunity is going to be different every time based on those factors. The virulence of the organism, the strength of the host, which is us, and how we intermingle in the contact rates. I hate to go back to my R0 slide, but again, it's proof that R0, although it's a great metric number, it doesn't measure the kind of to and fro interactions that people do. And then when people travel, when they go overseas, when they go to other places, again, there's another factor brought in. I hate to say we will know it when we have it, but unfortunately, that is the answer. We can't predict when we'll get there. We need to create our own future, as Dr. Halpern and Peter Drucker have said. We need to create our future, and that means vaccinate, boost, treat early, and continue those 4 W's of wear masks, watch your distance, walk away, and wash your hands. Thank you for the question.
It's fantastic advice. I will say that perhaps COVID-19 has taught us that as human beings, we're not always able to create our future because we've been at this for a while. And as you say, we haven't achieved herd immunity yet. So I would suggest that rather than thinking that we can create the future, perhaps we can hopefully influence the future. Next is a question for Jennifer Rickert. The questioner really asks about masks, but I think the question can be applied to vaccines as well, which is, how do we do a better job getting people to mask and to get vaccinated? Because we haven't been able to communicate that well enough.
Skip actually had a slide up earlier that when we're making decisions, when we're trying to get information across, communication is key. And that is so important that we continually get the message out in different mediums. So as an organization, we want to make sure we're letting our employees know the importance of masking and regulations. That's why it's also been so important for us to have our experts in the media speaking on various different channels about the importance of staying safe. And also you want to have different audiences speaking. So, you know, people in different communities getting the message across, elected officials. You have to talk to people where they are. and on social media, making sure that we get messages out that way. So again, it's all about communication and being consistent. Thank you for your question.
Sure. The second question is really both for you and for Skip, and I'll let you start, which is, how are you transparent when things are changing so rapidly? How do you effectively communicate when people want answers and you can't really give it to them because you don't know, because there's so much uncertainty? Even with our experts today, there are many things that people are just uncertain about. So what communication style would you use to try to alleviate some of that uncertainty?
Right. And as we've talked about throughout this symposium, information is so important and decisions are being made rapidly as new developments arise. So it's important that as leaders, as we're making decisions, that we're communicating them as effectively and factually as we can. So we want to make sure our different communities are not panicking about anything, but also not questioning, what's coming around the corner. So as soon as we have information, we want to share it. So when we're talking about back to work, we want to make sure we have a plan that takes in the needs of the audience. We don't want to say, next week everyone needs to be back in the office full time. As Skip said, we really need to be flexible, understand our community, and then continually update them and also have information flow back and forth. So we don't want to, as leaders, just make decisions and direct them down, but make sure we have town halls and different forums where people can speak to us so we can understand their needs and answer their questions. And now I'll turn it over to Skip to elaborate on that. Thank you very much.
Sure. Thank you, Doctor. Thank you, Jennifer. Take care.
Sure,
Okay.
thank you. And thank you. Those are all good questions, great questions. I guess it really has to be tailored to the company itself and what your staff or what your employees are most comfortable or using, or what they're most familiar with, so that they're actually getting the information or getting the announcements each day. The references I made were for companies that have already implemented the programs or initiatives that I said and had great success. But that doesn't mean that you don't tailor it for your specific company, because I know there were some people that had some concerns about that. How do they really do it? But tailoring it and keeping abreast to the fact of how your company best communicates and best looks and sees and gets their communications. Thank you for that question.
So we have another question who's skeptical about making physical return to work optional. How do you prevent that from causing chaos?
Another great question. Well, not making it optional means that doesn't necessarily mean that you don't make it mandatory. It's just that you have to do it and spread it over a period of time, get people used to doing it. When I made the reference earlier that commuting, I was shocked at how, in terms of doing some of this research, how many people have had to adjust their commuting to work since the pandemic. So things have influenced our life in so many different ways with this pandemic that we may not have really considered. So that I think we need to really be much more considerate of those things. So when we make these decisions, we make them over a period of time and ease them in, do it and with their buy-in. Thank you again.
Dr. Montecalvo, you had a comment about the pregnancy question that we asked earlier.
Yes, thank you. Yeah, the monoclonal antibodies are indicated in pregnancy. That's a recent change by CDC because of pregnant women being at high risk for the development of severe disease. So they are now part of that high risk group. Thank you.
Thank you. So I'll take the last question myself. Someone wants to know what we're doing at Touro and New York Medical College to protect everyone. So I will tell you that we've had a mandatory vaccination policy with extraordinarily limited exceptions at both Touro and New York Medical College for the past several months since the start of the semester. We've also, in most settings, mandated masking, although there are a few exceptions, but certainly in all the health science campuses, we've mandated masking. We're evaluating the data on Omicron on a day-to-day basis to determine whether any additional restrictions are needed. As you all, I'm sure, know, several colleges and universities have closed down because they've seen a spike in cases. We've not seen a significant spike at New York Medical College in Touro. There's a slight increase at New York Medical College. We've seen no spike at Touro. but we're monitoring things on a day-to-day basis to see if additional protections are necessary. But for now, we've been lucky, and the measures that the group has recommended have been effective at preventing a significant number of cases. I don't think we've had anybody ill from COVID in the last several weeks. So that's what we're doing. The health of our students, faculty, and staff is very important to us. That's why we have a vaccine mandate in place, and we'll continue to monitor things to make sure that we do as good a job as possible, keeping everybody safe while allowing the business of the university to continue. With that, we've reached 2 o'clock. I want to thank the panelists for great presentations and the audience for really a tremendous series of questions. We didn't get to all of them, but unfortunately, we'll have another webinar coming up. Thanks a lot, everybody.